everyone. It's another day with your fertility specialist on behalf of Alps Hospitals. I welcome you all to an interesting section with a day with your fertility specialist today we're talking about hysteroscopy. And to talk about hysteroscopy with us today is Dr. Kenneth Iguda. Dr. Ken, your smile.
I'm thinking of something else different.
So, for the sake of someone watching for the first time, a bit about Dr. Ken. He's a consultant gynecologist. He's a minimal access surgeon. As a matter of fact, the first to have pioneered laser gynecological surgery in Africa. He's also a fertility specialist, a very excellent one to the core at that. So that's a bit about Dr. Ken. But for now, let's talk about hysteroscopy. Like I mentioned, he's a minimal access surgeon, so it means that you couldn't have had a better person talk about hysteroscopy today. Now we're going to deal a lot more, but while we're getting started, please share this link with someone, call up someone, drop your questions, your thoughts, your opinions in the comment section, and we'll definitely respond to them appropriately. Dr. Ken, once again, I'm sure that this is one of the topics of interest to you, being
Yeah,
that you pioneered this laser gynecological procedure in Africa. So we'll talk a bit. What's even this hysteroscopy we're even talking about? Because that seems like a big word for a lot of people. So what is it?
yeah. You see, there's a woman who does hysteroscopies,
Okay.
in the United States,
No.
and occasionally we meet for conferences,
Hmm.
workshops, and all
Yeah.
of that. There was a time she delivered a topic,
Okay.
and that topic was very catchy.
Hmm.
In gynecology, in obstetric and gynecology, we that specialize in this field often don't have stethoscopes, or
Hmm.
rather, we don't use stethoscopes. Our stethoscopes are different. I don't want
Yeah.
to analyze what they say our stethoscopes are,
Yeah.
but her topic was once our hysteroscopes is our stethoscopes.
Oh,
You
interesting.
understand? So the way the cardiologist is a doctor who looks at the heart,
Yeah.
treats hypertension, treats cardiac abnormalities,
Yeah.
and all things that have to do with blood vessels, and the cardiologist. So they use the stethoscope a lot. Every doctor uses stethoscope at different degrees and different levels. What I think the cardiologist specially uses the stethoscope. So what the stethoscope is to the cardiologist is what the hysteroscope is to the gynecologist.
Psychologist. I see.
Because as
Interesting analogy.
gynecologists, we concern ourselves with the uterus and the ovaries and the area surrounding.
Yeah.
And as reproductive gynecologists,
Yeah.
we concern ourselves so much more with the uterine cavity, the uterus, the ovaries, and all of that.
Yeah.
And what tells us how healthy the uterus is,
Yeah.
just like what tells the cardiologist how healthy the heart is,
Yes.
the way it beats, the rhythm of the beating, the pace of the beating, and how quiet and how strong the beats are, is the stethoscopes.
Yeah.
And they have this stethoscope at different grades, in different grades. So our equivalent of the stethoscope is the hysteroscope,
Oh.
the telescope
Yeah.
through which we see the inner lining or the uterine cavity of the womb, the cavity of the womb, where implantation happen, where menstruation happen, where things can grow, where scars could be found, where a lot of lesions could be,
Yeah.
so
Yeah.
it tells us how healthy the uterus is, the history. So it's a telescope.
Okay.
It tells us how the uterus beats.
Oh yeah. So hope we got the analogy. So recently we talked about laparoscopy, and there are some people that would wonder if there's a difference. Is there really a difference? What's the difference between laparoscopy, hysteroscopy?
Okay, so it's a good one. Hysteroscopy just it's looking at or looking into the inner cavity
Oh,
or inner lining of the womb.
okay.
The womb is it's like let's assume it's like uh how do I like
How do we explain
How do you
so that they
explain?
can
Yeah,
understand
yeah,
it?
yeah.
Because he's
That's
trying to put it in a way
yes.
that we can
Okay, so let's say
understand.
the womb has the inner part
Hmm.
and the outer part.
Mm. Yeah.
Okay, the inner part is where menses comes from,
Yes.
where a woman menstruates or sheds
Mm-hmm.
every month if she's in the reproductive age and is
Yeah.
still within the age of menstruation. Okay,
Mm-hmm. Mm-hmm.
she sheds inside, so it's like you're looking into the mouth, for instance. It's part of the
Mm.
head, you know.
Yeah.
But so hysteroscopy looks into the
That
inner
inner
lining,
part.
the inner
Mm.
parts where
Okay.
menses comes from.
From. Mm.
But the laparoscope,
Mm.
you know, looks the outside
Oh.
surrounding of the
Oh.
womb. So there are two different
Okay.
procedures.
Mm.
They could be done differently. They could be done at the same time.
Mm.
They could complement themselves, seeing different perspective of the reproductive organ,
Yeah.
and all of that. Then the access point for laparoscopy is the abdomen,
Mm.
the abdominal wall, anterior abdominal wall,
Yes.
while the access point for hysteroscopy is the vagina and the cervix.
Okay.
So
Mm-mm.
these are two different things. They're
Different.
all cameras or telescopes, and they view the reproductive gonads or organs or surrounding
Yeah.
of the woman.
Okay.
Yeah,
Mm-hmm.
the hysteroscope is very small in size,
Yeah. Yeah.
and the caliber. The laparoscope is a bit bigger,
Bigger. Mm.
and all of that. But they are all used to operate the reproductive organs of women and the abdomen.
Mm,
Yeah.
okay, so viewers, hope we are noting that there's a difference, and for any point in time, should your fertility specialist recommend either of them or both of them, they have their reasons for, and he
Yeah.
has clearly defined, so we're able to differentiate the both. You don't just walk up to your doctor say I prefer laparoscopy over hysteroscopy.
Yeah. If I knew you were going to ask such a question,
Mm,
I would have loved to really be graphical with the analogy,
mm.
and having to deal with some images,
Oh, to show.
or with some videos to really
Mm.
explain, with explanation with the video would have made a whole world of difference.
Maybe one
Without
of.
talking, you see
Yeah.
what it is.
Maybe one of these days when we are doing our Q&As, we could prefer that.
Oh yeah.
We could prefer that. But viewers, hope that so now I know that yes, sometimes you would meet some clients that will say, but we've done ultrasound. Why do we still have to? Have they not seen the uterus? Have they not seen the womb? Why do I still have to do hysteroscopy? So are there some people that you would actually recommend having a stereoscopy for even after they've had their ultrasound? Or is there even a difference between the ultrasound and the hysteroscopy view? Yes.
Um,
Mm.
yeah. Ultrasound in the hand of a very experienced, well-trained uh, sonologist
Yeah.
could see and dictate a whole lot of things. Yeah. But yeah, and then if you hear the experts talk about ultrasound,
Yeah.
you know, they could actually come up with a lot of diagnoses using the ultrasound.
Hmm.
But my from an expert point of view, yeah,
Yeah.
at this point I'm an expert both in ultrasound and in laparoscopy. You can tell the difference. At best, it's still whereas you need to interpret signs, understand the signs, you know, to make diagnosis, to make judgments. Not everyone can operate ultrasound. Hysteroscopy is like you're watching a video,
Mm.
while ultrasound is like you're watching a shadow. You're trying to explain the shadow. So there's high chances that any ultrasound will get to make a real life diagnosis or the lab report, because you're watching in high definition and small objects are magnified for you. With history with lab report against the ultrasound, which is to a larger extent. So ultrasound gives faint, a faint detail.
Mm.
It could be precise with diagnosis. For laparoscopy, for hysteroscopy or laparoscopy, the blind person is that could tell what is seen is true or not. But it's not to say that everybody should have hysteroscope procedures should be conducted when they are necessary.
So that brings
So,
us to the question: when does it become necessary?
no,
For
even while you
someone?
are talking about that, there are other radiological or imaging modalities that
Yeah.
people compare with hystroscopy,
Hmm.
and one of them is HSG, for instance.
Okay.
You hear people say HSG can tell everything about the uterine cavity, especially a good number of clients that we see from Europe.
Hmm.
They say HSG can tell everything about the uterine cavity, and I say how? We've done HSG several times. I mean, countless number of times. And it could give an idea. And yes, your diagnosis could be correct, but hysteroscopy would tell a lot more details because you're watching. These days, we have these cameras not just in HD, we have them in 4K viewing. You understand? So you see more than what is even necessary when you're
Yeah.
viewing. And so you're able to tell whether this uterus or uterine cavity is fine or not as against
Yeah.
ultrasound. For instance, just like an hour ago, we concluded a hysteroscopy with one of the senior gynecologists in the
Yeah.
house. We have done an ultrasound. It was very big. The lining was not outlined and everything. We know there was lining, and she
Yes.
menstruates when she needs to menstruate or anytime. But well, when you it was totally it, you can't make those inferences. You just it's like, but how bad it is, quality or imaging. So, HSG history, but really good judgment. You know, HSG, saline HSG, you use a saline HSG, then and you try to make diagnosis. Most modalities, it doesn't show color. Even the color of the uterine cavity has a reproductive meaning. The tiny, tiny substances which we not see with sono HSG
Yeah.
or with HSG, we see with history and like polyps, for instance. So that's
Yeah.
very all of this diagnostic modality knows where history is not just standard, it is the diamond standard in
Diamond.
telling
Yeah.
the capacity of a uterine normality in the uterine.
And I hear you say your PT diagnostics. In those other ones, they really cannot
No, those ones
correct. So,
are yeah,
identify what.
diagnosis. It's less sensitivity, accuracy. You compare hysteros. So when you are doing hysteros, uh, when in part of you
Children.
surgeons, it's in, no matter how you do
No, so yes, so or who would you recommend hysteroscopy for? Seeing them come to your clinic, I know you have a lot of them coming. Who would you recommend? Clients say I didn't.
so we start from the people when you have advanced sensitivity comes with some complaint. We need to support us. And ultrasound will do some you may want to check once you the uterine cavity. Uh, approach to the one officer approach to could be is supposed to be the way to it could just go and treat at the same time. Now, uh, people actually do maybe menstrual
Yeah.
could be same as some of these people can actually see what
Hmm.
they could be so small, but they could be spread around and some of the people after so true. So if they really act on the uterine uh, and then it go for productive processes, I people had studies on the uterus, like fibroid surgery. Yeah, fibroid surgery, depending on the surgery, will be made with scar and then hystroscopy. What is how much value is help take care of the scar, treating the scar. Wow. People suspect it will not absolutely so it's like like top of the flesh of the stroke. Yeah. It was the they say you need hand training that with you see it directly.
Yeah.
And you don't have good training. You can say, "Ah," and then you probably will have to wait. Well, when you have to people what kind of activity, how and if you're center when you get to the stress message just go make the we are ready for when we see that if all the go through the process of groups to take out fibroids by those take out polish by those things to be discussed by those and you know about it. Then you're able to see if there are some people maybe have failed you know, the point feel you know, failure of IVF failure could be available. Good number of people so the uterus is just part of the uterus. So you want to check sometimes when it's having and treatment like with may benefit the see nutrition supplements because that as we know is usually a problem. So you may want to possible because of feel because that how good is still so it is quite it is quite great.
Yeah.
So from both reproductive perspective and just
Mhm.
general gynecology.
So viewers, a lot of actually been why hysteroscopy is very people that have had uterine surgery, people that
So,
have
so
had
sorry,
birth.
that's some other reasons. I just remember, sometimes some people have very difficult embryo transfers.
Hmm.
Yeah, and a good number of these cases, you don't know why it's just difficult. Yeah. Then you go with hystroscopes, for instance, and you see that a tiny seedling of fibroid has blocked the cervical canal.
No, wow.
Yeah, and then it becomes very difficult to have embryo transfer. So you
Yes.
just take it out, and the embryo transfer subsequently becomes a little easy. So I have quite a number of videos of such kind of fibroids that were blocking the entrance to the into the uterine cavity,
Yeah.
and those tiny fibroids are on the cervix,
Wow.
just the cervical canal.
Mm-hmm.
And then either ablate them, burn them,
Mm.
mayolize them, depending on the energy source you're using, and then next time embryo transfer becomes easy because it's a difficult embryo transfer could be associated with failed IVF outcome.
It's true.
So there's a lot you could just
Lots.
see, more especially if you're doing a hystroscopy with the vaginoscopy approach. But this is for gynecologists, not in terms of
Okay, so
for people.
viewers, yes. So before Dr. Ken chipped in this, I was saying that, he mentioned something about people that have had uterine surgery, people that have had DNCI. I was thinking, oftentimes, you see clients that maybe had surgery. I'm sure Dr. Ken must have seen a lot of this, and then by the time they are coming for a check, you just feel like they finished the woman's endometrium, like it's damaged. And you just wonder, is it that sometimes some of these doctors that are seeing this woman or attending to this woman, is that they are not thinking of a fertility prospect, or sometimes maybe quacks that they might have even met to do maybe D&C like they would have done, or even sometimes some of them, the people that have had maybe miscarriage, sometimes they just want to take out everything to make sure. I know that there was a time Dr. Ken mentioned they want to feel that gritty
We did
sensation.
that as residency. God have mercy on us.
So,
Oh dear.
and then the next thing the woman is battling with fertility. So this is to draw our attention that sometimes when we try to assess some of this care, we respect maybe having a uterine surgery, maybe like a fibroid surgery, or even when they want to even do maybe evacuation for people. I think that you should assess such care from people that are highly professional. I actually spoke with a client yesterday, and somehow, sadly, they had a missed abortion, and then somehow they are considering maybe doing an evacuation. So I had to let her know, please, whoever it is that will attend to you, let them attend to you with the notion that you still want to get pregnant. They should not finish,
Mhm.
they shouldn't just cause a damage that you now have to start struggling. Maybe now, maybe something else is the problem. Now we now have to add this one to the problem and start thinking of that. So let's all viewers be mindful. If you have people that are seeking help for fertility or trying to assess one care of the other, it's good that they know they go to the right place to see the right people. Like you have good and very high expertise at house hospitals, not just high expertise, but you have people that are well trained globally to be able to attend to you, to pay good attention to your lining, good attention to everything with respect to your fertility. Anybody attending to you has it at the back of the mind that this person might be looking at achieving pregnancy, even as a young person coming in, and not just living anyhow or attending meeting. Sometimes even the young ladies, they don't care about later. It's just now. They just want to, maybe we want to do termination of pregnancy, and then they don't want to know how it's done. They are just thinking of now. For instance, should it be that such a person has now gone through so much like that, and then now you are now dealing with having to deal with fertility issues, you will now wish you actually went about it the right way, or you had a missed abortion, you went about it the right way. So I'm drawing our attention that this is actually a thing of concern, where we seek help from, or where we get attention from with respect to reproduction, is very, very key. Is very, very essential. Please, let's take note of these and make sure we're seeking help from the right source. So back to you, Dr. Ken. Another thing that people would wonder, is this procedure painful? How long does it take? Will I sleep in the hospital and all that? Do I need to pack everything and come and stay because I'm coming in for hysteroscopy? So maybe give us a walkthrough about how this procedure would be and what it takes, how long it takes, and all.
Oh, well, hysteroscopy falls among the categories of procedure usually called the daycare procedure.
Oh, okay.
And then largely there may not be need for admission for just basic hysteroscopy. There may not be need for admission. You just come, have the procedure, and you go. In apps, for instance, for those who merit hysteroscopy, it may just be part of their clinical evaluation. They walk into the hospital, and in the next 2 to 3 hours, they've had evaluation and had hysteroscopy, and they are going. And
Wow.
oftentimes they don't use anesthesia. Yeah, occasionally, or yeah, occasionally we use what we call the cervical block, paracervical block,
Okay.
where you just give injections on the cervix to just numb part of the uterus, and then you just view what you have to give you. But of course, some people will be so anxious that you're not able to even touch them, and so
Hmm.
you may have to give a little more advanced anesthesia,
Anesthesia. Hmm.
or sedate them,
Hmm.
so you could do what you have to do. But the sedation will still clear within the same day, and they leave the hospital. So,
Hospital. Okay.
except of course, if you have complications, which of course is also possible with, then you want to keep them and monitor for safety before you let them go. Yeah. Uh, Straightforward hysteroscopy is not painful,
Hmm.
but may have some discomfort, which may range from pain, lower abdominal pain,
Yeah.
and a good number of, I mean, good amount of the pain is usually from the uterine distension,
Hmm.
because once the fluid used to have a clear view is
Yes.
being flushed out, the uterus keep cramping to push out
Mm-hmm.
all
Mm-hmm.
the fluid. So
Okay.
they have cramps, like menstrual cramps.
Okay.
So they usually will live with some pain meds,
Okay.
and then life goes smooth. So, by and large, it just has a lot of discomfort, less of pain, I think.
Mm-hmm.
Then for very complicated hysteroscopy, they are given anesthesia, and then with the anesthesia, they don't feel pain. So it's not a procedure that anyone should be scared of.
Okay. So viewers,
Mm.
hope this has allayed your fear.
Should be scared of.
Hope this has allayed your
Uh,
fear. So yes, he has mentioned to us, so we know that it's not as bad as you're thinking. That's why sometimes the gap of knowledge, when we're not aware, we just think it's a very, very big procedure. You have to come and sleep in the hospital and all of that, except when complications are, of course.
yeah.
So that's for hysteroscopy. Well, as we wrap up on this show today, what's your counsel for generally respect to hysteroscopy?
Yeah, I think people should keep an open mind if they've seen an expert, especially expert in reproductive medicine. Yeah, because for us, the way the cardiology listens to your heart when you come to be evaluated
Yeah,
for blood pressure and heart related conditions.
yeah,
Sometimes even when you don't have a problem, the cardiologist listen to your heart. He just
it's
wants to
true.
listen to the heart,
Mm-hmm.
just to be sure. Because
Yes,
some of these problems are subtle. You don't even know until you just pick them up. So
yes,
it's like routine for the of cardiologists to listen.
yes,
So I'm
yes.
not saying the gynecology should do this as a routine anyway,
Routine. Mm.
but it should be used when necessary to evaluate the uterine cavity,
Mm-hmm.
especially when people have gynecological related problems or planning for advanced fertility care. And
Okay.
if that becomes the need for any clients, I think they should carefully and happily consider it.
So viewers, yes, the take home is have an open mind and don't compare notes. Like he mentioned, we've seen people that it's necessary for them to have it, and there are some that they might just feel you can go ahead to start whatever treatment you want to start. So just have it open.
Yes, one more thing. The general public
Yeah.
actually have a bias for clinical investigation or
Mm-hmm.
clinical evaluations.
Yeah.
They feel that once you evaluate, you find a problem.
Hmm.
Yes. So when problems are not found, they
You
feel
feel
they've been cheated.
yes.
No, but now that is not the essence of evaluation.
Mm-hmm.
Evaluation or investigations, where of course hysteroscopy falls in as one of those modalities for evaluation and investigations. Investigations are meant to either clear you or to find out something. So, and this helps the doctor in building up his judgment,
Hmm.
you know, and modalities of treating you. So, investigations are not necessarily meant to find out what we set to find out. It may just be to clear our minds from what we are afraid of.
Hmm.
In which case, whichever way your outcome is, it is a welcome intervention.
Mention.
So you could do hysteroscopy and it is just normal.
Normal.
And it is not like the doctor just wants to punish you or wants to take advantage of you. It just helps him to tell that we're okay to go on.
Hmm.
And if it's not normal, he knows there's something that we need to fix to make you normal. So Not every checks reveals something sinister. Some may just clear and clear our doubts that you're ready to go.
That's a good point to note. Thank you so much, Dr. Ken. We had a good time with you. I know our viewers also had a good time. Thank you so much, viewers, for staying glued to your screen. We look forward to seeing more of you, and I hope that we've all jotted our notes from this. So, for now, enjoy the rest of your evening. Bye.
Mhm.
Thank you so much, viewers, for staying glued to your screen. We look forward to seeing more of you, and I hope that we've all jotted our notes from this. So, for now, enjoy the rest of